So this is what a typical EKG looks like for atrial fibrillation, just irregular rhythm, no discernible P waves, normally tachycardic, but not always. And I just went into the CDC website a few days ago, and 12.1 million people have AF in the US, 454 hospitalizations and 158 deaths occur each year in the US due to AF. And in 2021, AAF was listed as the cause of death in 28,000 death certificates. So not an insignificant condition. It's considered at this point a global pandemic. And if you can see here on the maps, certain countries with, just poor lifestyles and, perhaps a lot of smoking, who knows, alcohol use. The American Midwest and South, probably just more obesity, more smoking can contribute to a higher percentage of atrial fibrillation. The overall prevalence among Medicare beneficiaries, the overall prevalence is going up. The prevalence has gone up and continues to go up. It's a disease of the elderly patients. So the older we get, the more likely we are to have atrial fibrillation. Men are more likely to have AF compared to women, and Caucasians over African Americans and other people. Classification types of AFib. There's episodic. An episode of AFib needs to last at least 30 seconds. If it's less than 30 seconds, we typically call it atrial tach, or it needs to be captured in a 12-lead ECG. Paroxysmal AF is an episode that occurs spontaneously, terminates spontaneously, or with an intervention such as giving IV cardizem or amiodarone or cardioverting the patient within 7 days. Persistent AFib is continuous AFib that lasts longer than 1 week, and we call it early persistent if it's less than 3 months, and long-standing persistent if it goes on for more than 12 months. And then permanent AFib is basically a decision that we make between physician and patient that there will be no further attempts to restore sinus rhythm, and you're just going to live with atrial fibrillation, which is the case for some patients. In the more recent guidelines that were updated in 2024, by the way, this document here and another document that I will share, but this is the new guidelines that came out in the beginning of 2024. It's almost a 200-page document or 156-page document, and you can read through it. There's a lot of data. I'm going to try to hit the highlights, but they included the at-risk classification here, which is pretty much most of us, right? Or a lot of adults, overweight people, lack of fitness, hypertension, sleep apnea, alcohol, diabetes are all risk factors that can contribute to the development of AF. There's also the pre-AF category, and these are patients that on echo would have dilated atria, dilated left atria. They have a lot of PACs, a lot of ectopy, bursts of atrial tachycardia. All those things kind of predispose you to develop AF. Then in we have 3A through 3D. 3A through 3C are what I just explained, paroxysmal persistent and long-standing persistent. 3D is a new category. Those are folks that have undergone ablation and they are free of atrial fibrillation but carry all this background. And then permanent AF, as I just mentioned, is when we sort of give up and we accept the AFib as the rhythm. Terms that are no longer used. Valvular AF has kind of fallen out of the guidelines. This was AF in the presence of rheumatic mitral stenosis or a mechanical or biprosthetic valve, or anyone that has had mitral valve repair. The term chronic AF has fallen out of the guidelines, and also lone atrial fibrillation, which was a description of a young patient that maybe was over-caffeinated and went into AFib, and there was no other risk factors, and it never happened before or after that one episode. So that terminology is also gone. In terms of prognosis, basically, this is a busy graph here, but everything is in yellow. It's basically an ischemic stroke, and ischemic strokes are by far the most common types of strokes. And cryptogenic strokes are ischemic strokes where you don't have a source. You don't know exactly why it happened. So 1/3 of ischemic strokes are cryptogenic, and 1/3 of cryptogenic strokes occur in the setting of AF. So roughly 1/3 of 1/3, somewhere between 10 to 15% of all ischemic strokes are related to AFib. And in the pre-anticoagulation era, non-valvular AF had a relative risk of about 3 to 5-fold of having a stroke in your lifetime. And with rheumatic heart disease in particular, that risk increased to 18-fold. Also, AFib is the risk of venous thromboembolism is increased during the first 6 months after AF is diagnosed, with a hazard ratio of 8.4. AF increases the risk of end-stage renal disease in patients with CKD, and that's a hazard ratio of 1.7. There is an increased risk of MI in patients with AF with a hazard ratio of 1.7. AF increases the risk of congestive heart failure and vice versa, and the combination increased mortality. And there's also a 1.5 to 2% to 2-fold increased risk of sudden death and total mortality, especially in women. There is also significant morbidity. It's probably more of a morbid condition than a condition that causes mortality necessarily, but people come in the office, they complain of palpitations. The elderly, usually the presenting symptoms are easy fatigue and tiredness. They may not say that something it's not crushing chest pain that brings them to the ED. It's usually, I just can't walk from here to the bathroom without feeling tired and fatigued. And I just feel that fatigue is, in my opinion, just probably the most common symptom in the elderly. Reduced exercise tolerance and diminished quality of life. They may have tachycardia-mediated cardiomyopathy, and again, it's associated with an overall increase in mortality of 1.2 to 2-fold. These are risk factors, and I'm going to go through this in a bit more detail, but essentially patients with hypertension, obesity, sleep apnea, hyperthyroidism, and alcohol and drug use predispose you to developing atrial fibrillation. Also, inflammatory conditions, any type of viral illness, a fever, and pneumonia, having had surgery recently with stress, surgical stress can initiate AF, and it's generally in patients that have some predisposition, some dilatation of the atrium, some fibrosis in the heart. The mechanisms of AF. So there's the multiple wavelet hypothesis that dates back to 1962, was widely accepted as the dominant AF mechanism, and that AF is maintained by multiple independent wavelets that propagate randomly throughout the atria. Multiple wavelet hypothesis favored by slowed conduction velocity, short refractory periods, and increased atrial mass. There is also the hypothesis of focal triggers that was proposed in 1947, but in the 1990s, Hasegawa and Pierre Zay in Bordeaux, France, were credited with making the observation that it was the pulmonary veins that triggered, with focal foci coming from the pulmonary vein, initiating essentially atrial fibrillation, and that ablation of those foci led to elimination of AF. When they first started doing AF ablations, they would go into the pulmonary veins and cauterize spots. And then they realized that you have to essentially isolate the pulmonary veins, and ablation within the pulmonary vein causes pulmonary vein stenosis. So as always, there are things that we don't know when we initiate a new procedure, and you learn as you go. So that was a learning lesson for them. This is a schematic of basically these different mechanisms. So multiple wavelet hypothesis, triggered activity from the PVs, micro reentry. There's a difference in the conduction on the endocardium and epicardium that can cause dispersion of repolarization and essentially trigger AF. This is functional reentry. Basically, if you're rotating in a certain spot over and over again, that spot becomes almost like an anchor for a spiral, and that can also maintain atrial fibrillation. Some of these are not fully understood, and you can't necessarily see these, but these are hypothetical mechanisms of AF. This is the seminal paper of Michel Hasegawa and Pierre Zay from 1998, and as you can see here, they demonstrated with this diagram where the PV foci, which foci were firing. There were a few outside of the pulmonary veins, but the vast majority, 94% of the foci, were within the pulmonary veins. This is the second document that you should consider reading if you're interested in this topic. This is from the European Heart Rhythm Association and published very recently. It's also a 107-page document, but it's basically the European guideline. But electrical remodeling with calcium dysregulation and leaky ryanodine receptors can lead to delayed after depolarization and trigger AF. There's also ion channel dysfunction leading to early after depolarizations and triggers, decrease in action potential duration, refractory period, and conduction velocity lead to reentry prone substrate. There is also an element of structural remodeling or atrial fibrosis that has implications for both firing and propagation of the arrhythmia. And there's also the autonomic nervous system that's involved in this process of developing AF. In a few words, it's spontaneous diastolic calcium release from the sarcoplasmic reticulum via leaky ryanodine receptors. There's an increase in IK1 in the left atrium, causing heterogeneity between the right atrium and the left atrium that promotes arrhythmogenicity. There is downregulation of connexin, resulting in decreased gap junctions, leading to slow heterogeneous atrial conduction velocity and repolarization. Basically, the atria of patients with AF tend to have both shorter refractory periods, slower conduction, which enhances dispersion of repolarization and favors reentry. And this substrate is sensitive to AF initiation after frequent PACs, and the overall PAC burden is associated with the development of AF. And generally, you have larger left atrial volumes, increased NT-proBNP levels, impaired left atrial emptying, and associated increase in PAC burden and the development of AF. This is an older slide, but I kept it in my presentation because the point that is driving across is that larger mammals such as whales, elephants, and horses have larger atria, so more substrate to maintain atrial fibrillation, whereas rabbits and cats in the lab, they're very difficult to actually induce and put in atrial fibrillation. And humans were kind of right on the cusp of that fibrillation threshold, that as we progress through life with more fibrosis and enlargement of our atria, we're more prone to go into atrial fibrillation. So this was basically the premise of development of the Cox-Maze procedure, which was aimed to compartmentalize the atria and prevent propagation of these multiple wavelets. And it was proposed and introduced by Dr. James Cox in 1987. And complications of the early versions of the Cox-Maze procedure was chronotropic incompetence and high incidence of postoperative pacemaker requirement. The Cox-Maze procedure evolved, but it essentially became the gold standard for many years as far as treatment and cure for atrial fibrillation. But it involved several lesions that are shown in this diagram. This was a more recent study published in the New England Journal of Medicine in 2015, but essentially they took patients that were undergoing mitral valve surgery and they offered them either surgical ablation for AFib along with the valve surgery or just the valve surgery. And basically they demonstrated that the addition of the AF surgical ablation at the time of mitral valve reduced the rate of AF at 1 year among patients with persistent and long-standing persistent AF, again at the expense of an increased risk of pacemaker implantation. And in our more recent guidelines, you see up here that for patients undergoing cardiac surgery, concomitant surgical ablation can be beneficial to reduce the risk of recurrent AF. That's a 2A indication. I'm going to skip this. And then in patients with who are refractory to antiarrhythmic drugs, a hybrid epicardial and endocardial ablation might be reasonable to reduce the risk of recurrent arrhythmia. That's a 2B recommendation. Rate versus rhythm control. So this dates back to 2002 and 2005. When I was in medical school, this study came out, the AFFIRM study, and it basically showed that rate control was almost essentially equal, if not better, than rhythm control. So rhythm control strategy offered no survival advantage over rate control, but there was a lower risk of adverse drug effects with rate control strategy, right? There are simpler medications, beta blockers and digoxin versus flecainide, propafenone, or amiodarone. The RACE study was published a few years later, where they demonstrated that routine rate control prevents deterioration of LV function, and that the maintenance of sinus rhythm is associated with improvement of left ventricular function and reduction of atrial sizes. And this was published in two subsequent papers. A few months later, they demonstrated that in patients with mild to moderate CHF, rate control is not inferior to rhythm control. But however, if sinus rhythm can be maintained, outcomes may be improved. The criticism with these studies is antiarrhythmic drugs, we know, have they're complicated drugs. They have side effects. People can become profoundly bradycardic. They can go into other arrhythmias. We know from the CAST study that the class 1C agents are contraindicated in coronary disease. We know that amiodarone has toxicities. We know that sotalol and ticozin can prolong the QT, and they're contraindicated in renal failure. So they're just not simple medicines. We use them all the time because we have to, but very cautiously, and you have to find the appropriate drug for the appropriate patient. As far as rate control, on the most recent guideline, if the patient is hemodynamic, so acute rate control, if the patient is hemodynamically unstable, you should cardiovert. So if they're tachycardic and hypotensive and fainting, you should cardiovert them. If they're hemodynamically stable and in congestive heart failure, you should use IV amiodarone. If they're saying as a rate control agent here, and verapamil or diltiazem can cause harm in the acutely decompensated patient. Beta blockers, digoxin, and amiodarone is what we normally use in most patients who are not decompensated. And as far as long-term rate control, in patients with preserved ejection fraction, you can use either beta blockers or calcium channel blockers, specifically diltiazem and verapamil, or you can use digoxin as a 2A indication. If their EF is reduced, moderately reduced, beta blockers and digoxin, they took out, obviously, calcium channel blockers. And dronedarone is not a rate control agent. It's an class 3 antiarrhythmic. But it's contraindicated in permanent AF, and also contraindicated if the patient has history of decompensated heart failure or recent hospitalization for heart failure. The Cabana trial was a trial that started in 2009. It gathered a lot of attention. It was a Mayo Clinic Duke study. The first author is a famous electrophysiologist, Dr. Packer, and they compared ablation to state-of-the-art drug therapy for patients with new onset and untreated AF. The primary endpoint was all-cause mortality, disabling stroke, serious bleeding, or cardiac arrest. And the major secondary endpoints were all-cause mortality, death, or cardiovascular hospitalization. They enrollment started in 2009. 43% were patients were paroxysmal, 47% were persistent, and 10% were long-standing persistent. There was the medical arm could be either rate or rhythm. Both were acceptable, and 12% of patients received rate control only. If you look at the intention to treat analysis of the Cabana study, which was presented at HRS in San Francisco in 2019, it showed no major difference. If you look at the per protocol analysis, there was a significant difference in favor of ablation. The critics would say, it was a negative study. But basically what happened was that 30% of patients that were assigned to the medical group crossed over and underwent ablation. And then 10% of those that were assigned to ablation decided not to proceed with the ablation. So there was so much crossover that it diluted the result. I'm not saying it, you can interpret this whichever way you want, but I'm going to show you some additional studies that I think clear up things a little bit. The Cabana take-home messages are that that ablation is no worse than medical management, that it's a viable alternative to drugs, and that for symptomatic patients, it can be offered as first-line treatment. And generally, it's a better option for younger patients, minority patients. I'm not sure exactly why that is, but and patients with CHF class 2 to 3 symptoms, and generally worse for elderly patients. Again, this is 2009 to 2019. Things have evolved since then. And also that not everyone needs an AF ablation. I thought the CAST-AF trial was a very good study. Published in 2018. They took patients with symptomatic AF, paroxysmal or persistent, heart failure class 2 to 4 symptoms, and EF less than 35%, and they randomized them to catheter ablation or medical therapy, which again was rate or rhythm, on top of their guideline-direct medical therapy for CHF. And the CASTLE-AF study showed a significant benefit with ablation, so that catheter ablation in patients with CHF was associated with significantly lower rate of the composite of death or CHF or hospitalization compared to medical therapy. Another study, the CAMERA MRI, published in 2017 in JACC, they looked at catheter ablation for AF that could improve left ventricular systolic dimension compared with rate control, where the etiology of LV dysfunction was unexplained. These were patients with persistent AF and an idiopathic cardiomyopathy with an EF of less than 45%. All of the subjects had cardiac MRI to assess their EF and to evaluate for late gadolinium enhancement. I will explain what that is in just a second. 68 patients were randomized, and catheter ablation included posterior PVI and posterior wall isolation, which was done with what we call a box lesion, so a roof line and an inferior line. This was radio frequency ablation, just kind of our standard run-of-the-mill ablation technology that we had for many years. Essentially, the ablation was associated with a significant improvement in LVEF, and this finding was accompanied by reductions in atrial and ventricular chamber dimensions, reduction in BMP levels, and New York Heart Association class. LGE, late gadolinium enhancement, we have experts in the room that read cardiac MRIs, but it's basically the best way I understand it is that gadolinium doesn't wash out in and out of fibrotic diseased cells. So it usually lights up scar, any type of scar or fibrosis. And in the CAMERA MRI study, the absence of LGE on cardiac MRI was associated with a greater improvement in LVEF and a higher likelihood of normalization of left ventricular function. So essentially, if somebody had a reduction in the EF that we probably felt was tachycardia or AF mediated, then they were most likely to benefit from an ablation. The antiarrhythmic drugs that we use, amiodarone, one of the most common. Efficacy, the highest efficacy in terms of antiarrhythmic drugs. Its efficacy is about 60 to 65% and was confirmed in multiple studies. Propafenone has efficacy of 37%. Sotalol, the same. Dofetilide. So propafenone actually and flecainide are about 35 to 40%. So is sotalol. Dofetilide requires a 3-day admission to the hospital for initiation because it causes QT prolongation. The efficacy of dofetilide ranges between 37 to 58%, and it depends on the dose. So the higher dose of dofetilide gives you an efficacy closer to 60%. That's 500 micrograms twice a day. The lowest dose, which is 125 micrograms twice a day, is closer to 37%. For certain patients, it is a great drug. It's just that nobody wants to be admitted to the hospital for 3 days to be initiated on dofetilide. Another name for it is Ticosin. Dronedarone was supposed to be the wonder drug and the replacement of amiodarone. They took out the iodine moiety of amiodarone. It reduced, and it didn't eliminate, but reduced the side effects, the potential toxicity and side effects of amiodarone, but it also made it less efficacious. So the efficacy in the Dionysus trial was 42%, but in real life, we think that it's closer to 20%. And placebo, if you do nothing, if you don't give them anything, is about 13 to 20% chance of being AF-free at 1 year in most trials. So that's just as a point of reference to the rest of your antiarrhythmic drugs. The most recent guideline in terms of what antiarrhythmic drug to use. So if you have normal LV function, no prior MI, no significant structural heart disease, you can pretty much use everything. You can use dofetilide, dronedarone, flecainide, or propafenone. Those are all 2A. You can go to amiodarone, also a 2A. We usually don't start with that because of, as you know, the side effect profile. And sotalol is a 2B. If they've had prior MI or significant structural heart disease or an EF less than 40%, then we're more limited as to which antiarrhythmic drug we can use. So flecainide and propafenone are contraindicated in ischemic patients. You can use amiodarone, you can use dofetilide, you can use sotalol. Dronedarone, which is Multac, if they're not in heart failure, you can use it. But if they have acute decompensated heart failure, or just they're in and out of the hospital, or they're volume overloaded all the time, then it's a contraindication. It can cause harm. It can cause more admissions for heart failure. So catheter ablation is a big topic for AF management. What we do quite frequently. It requires, so AF requires both a trigger and a susceptible substrate. And the goals of AF ablation is to prevent AF by either eliminating the trigger or altering the arrhythmogenic substrate. And often you have to do both. Back to this slide from the original paper, targets for a PAF are usually the pulmonary veins. These are a couple of schematics of demonstrating standard radiofrequency ablation that has existed since the 1990s. I describe this as spot welding to the patients. You're basically going point by point and trying to fence in the pulmonary veins and eliminate electrical impulses. We've used this for nearly 15 to 20 years. Before around 2010, we transitioned, at least at MedStar, we went from a heavy RF program to a heavy cryo program. So this is, cryo is basically a single shot technology. You introduce the catheter in the left atrium, you find the vein, you inflate the balloon, you occlude the vein, and nitrogen gas is injected in the cryo balloon, and you get temperatures of like minus 50 degrees Celsius that essentially crystallize the cells and make them electrically inert. And you do several applications of freezing. It worked great. Both of these technologies were very effective. Essentially, the end point of an ablation is amplitude reduction within the ablated area, elimination of the PV potentials recorded from a circular mapping catheter. That's the circular mapping catheter, and that's also a circular mapping catheter. And demonstration of entrance and exit block from the pulmonary veins. You essentially pace to capture in the pulmonary vein, but you want to make sure that that signal doesn't get into the left atrium to capture the left atrium. You cannot accelerate the left atrium. And this is a demonstration of some intracardiac tracings, but this catheter is basically in the coronary sinus. It senses atrial signal. This is your surface ventricular signal. And what you're seeing here is this 4 channels here are in the pulmonary vein. You have some far field A and some far field V, and this is your pulmonary venous potential. And as you're ablating and eliminating it, you can see that it spaces out, and ultimately you completely dissociate it. So the atrium is firing and it doesn't enter the pulmonary veins, and the pulmonary vein can fire, although sometimes these signals are completely eliminated. But this is a wonderful result here. If you have a firing of a pulmonary vein that you cannot capture and accelerate the atrium. So this is both entrance and exit block. I'm going to skip this slide. This is an older slide, but essentially the more recent guideline, patients with symptomatic AF in whom antiarrhythmic drugs have been ineffective, contraindicated, or not tolerated, or not preferred, and continued rhythm control is desired, catheter ablation is useful to improve symptoms. That's a class 1 recommendation. That's the same level of recommendation as a pacemaker for complete heart block. In selected patients with symptomatic paroxysmal AF in whom rhythm control is desired, catheter ablation is useful as first-line therapy. So this was a change, right? Before, we said you had to, and if you go back to this slide, you had to sort of try an antiarrhythmic drug first and then jump to catheter ablation. Then these were 2A indications, and now they've become class 1 indications. And in patients, if they have atrial flutter, you should consider ablation for that. They also talk about efficacy. I'm sorry, cost efficacy or cost analysis. Basically, you can yes, an ablation is a fairly expensive procedure. Usually, the patient pays a certain amount out of pocket, but if you consider the overall cost of somebody being admitted and readmitted, or another ER visit, another cardioversion, versus just getting an ablation, it may be more cost-effective long-term to just get an ablation earlier on. That's what, catheter ablation for symptomatic AF provide intermediate economic value compared with antiarrhythmic drug therapy. So somebody has to do the math and figure that out, but this is a diagram of the algorithm, but paroxysmal AF, if they're symptomatic and resistant to drugs, ablate. It can also be offered as first-line treatment. Persistent AF, symptomatic, resistant to drugs, ablate. It can also be offered as first-line treatment, but gray, this is the European guideline, gray means less certain. And this is a difficult decision-making, if you ask me, because the patient comes in, they're asymptomatic. You interrogate them, you ask them, are you sure you're asymptomatic? They're truly asymptomatic. They're working out, they're exercising, they live a normal life, but they're 60 or they're 50 years old, and they don't want to be in AFib for the rest of their life, right? It's just, they realize it's an abnormal rhythm. There's an increased incidence of stroke. So then you have to have a talk with them. What is it that you're looking for? And, what are the benefits? Is there any benefit to proceeding with ablation? This is why this is a gray zone. And especially offering it as a first-line treatment on somebody who's completely asymptomatic. If you ask some of my partners, they'll say, well, they're never really completely asymptomatic, but there are indeed some people that are truly asymptomatic, and I've followed them for years, and they've remained asymptomatic, and for the right patient, if that's the patient's decision and desire, then you abide by that, do that, follow that path. Indications for ablation in patients not well represented in clinical trials. So it's a 2 indication if somebody has congestion related to AF. You can use it on a symptomatic patient who's over 75, and somebody who has hypertrophic cardiomyopathy, younger patients who don't want to be on drugs, or folks that have Tachy-Brady syndrome and conversion pauses. So instead of necessarily offering them a pacemaker, you can say, well, let me get rid of the AFib first and see if you continue to have pauses and sinus node dysfunction. And in many instances, you can obviate the need for a pacemaker because you got rid of the tachycardia, you can stop their beta blocker, and now they're not having any pauses. In athletes, especially people that want to have a professional career and they don't want to be on drugs, or the drugs limit their cardiac output and their athletic ability, they will often ask you to get an ablation. And one of my first experiences as a resident was somebody came in and was an ophthalmologist, and who was not swimming competitively, but swimming quite a bit. And he said, every time I go into AFib, it really limits my ability to swim. And my attending at the time offered them an ablation, who was otherwise asymptomatic, other than I just can't swim as long when I'm in AFib. And down here as a 2B, this is from 2017, but down here as a 2B indication, even in asymptomatic patients, you can offer it if that's what the patient wants. So the goals of radiofrequency ablation is to deliver high power delivery of energy. You have to have good tissue contact. We use steerable catheters, steerable sheaths, and contact force catheters were a game changer back in 2012. They used to do ablation without irrigation, but there was increased higher chance of stroke because of char formation on the catheter. So all the companies switched to irrigated catheters. There's no definitive proof that they reduce complications, but the industry has a sense of pretty much all the catheters, if you use RF these days, they're all irrigated. And contact force, as I said, was a kind of a big deal back in 2015. We adopted cryo very early on at MedStar. We were one of the first places to trial cryo, and then we've had it for many years. And I have to admit that we've had incredible results with it. I really enjoyed this technology. It was a little more forgiving to the tissue. Temperatures would get down to about minus 50 degrees Celsius. The initial concern about cryoablation was that there was a higher chance of phrenic nerve injury, which we did not experience. That was kind of part of the original trial, but we used the technique, and I'll explain how we did it. But we would stimulate the phrenic nerve, and if we felt any diminution in the diaphragmatic stimulation, we would terminate the freeze. And with that strategy, I've seen a few pulses, but I've never had any permanent phrenic nerve injury. Places like UPenn never adopted cryo because they were concerned about phrenic nerve injury. And several other institutions did not adopt it, but we did. This is what cryoablation looks like. It gave us very nice uniform lesions, and it's considered what we call single-shot technology. There was also laser technology that was a balloon-based technology. We never got that, but several institutions in the country use it. These are just images from just a cryoablation. I'm not sure if this will play, maybe not. And then we also use the cryo balloon to treat the posterior wall just by maneuvering the balloon and kind of pushing it up against the posterior left atrial wall. This was the Fire and Ice study that compared cryo to the standard of care at the time, which was radiofrequency ablation, and the results were essentially the same. It was a non-inferior to radiofrequency ablation with respect to efficacy with PAF, and there was no significant difference between the two methods with regard to overall safety. This is kind of what you aim to achieve. This is a voltage map, a validation map. Purple means healthy electrical tissue, and red is something that's been isolated, and the blue and green is kind of the border zone. These are different anatomic variations of the left atrium. Standard anatomy, you see this, you're happy, great. There's sometimes some folks have a common left ostium. Sometimes there are more than 4 veins. Sometimes you have inferior veins that have a common ostium or a funny pulmonary vein draining in some just strange or just not standard anatomy. And there can be other miscellaneous anatomic variations. We treated recently a few patients that had a lobectomy at some point, and it really distorts the anatomy, and it can really make the procedure complicated. PVI alone is the standard of care for paroxysmal AFib. PVI alone is it's important in persistent and long-standing persistent, but it may not be enough as the sole strategy. So over the years, and when we go to our national meetings, everybody talks about what's new, what else can I do for persistent AFib? And at some point, they were recommending ablation of what we call CAFEs, complex fractionated atrial electrograms. It became very popular, and it kind of lost all its popularity within a few years because I'll show you a study that was done at UPenn that demonstrated that it really makes no difference. Linear ablation lesions like a roofline or a mitral isthmus line or a posterior wall isolation, that was something that was done for many years for the more advanced cases. People ablated in the superior vena cava, the coronary sinus, ligation of the ligament of Marsall, targeting ganglionated plexi or the crista terminalis. There was a system called FIRM made by a company called Topera that VHC had for a little while. That has fallen out of favor. The Bordeaux group proposed body surface mapping with like externally looking to see what other triggers may be in the left atrium. So these are all just supplemental ablative strategies. This was I believe this was the STAR AF study was a UPenn study, but they looked at standard PVI with CAFE ablation or PVI with a roof line or a mitral line, and essentially it showed no reduction in the rate of recurrent atrial fibrillation when either linear ablation or ablation of cafes was performed in addition to PVI. So, as I said, just as they gain popularity and people start doing these additional steps because somebody posts something somewhere or a study gets published, then another study comes along sometimes that, contradicts that. So the issue with linear lesions is you can have incomplete lines or recovery of certain areas, and that becomes a nidus for atrial attacks or micro reentry. And the role of additional lesions in persistent AF remains controversial, and routine isolation of the posterior wall does not seem to achieve better results. So that's a posterior wall isolation. This is a standard PVI, and this is what we call a posterior wall isolation. I tend to do posterior wall isolation. I think in my personal experience that it adds some value. And the bottom line is if somebody has had a PVI and you confirm that it's a durable PVI on a redo procedure, what else do you have to do something else? Embryologically, the pulmonary veins and the tissue of the posterior left atrial wall is very similar tissue, so it can also fire and cause AFib. And when you look at PVI plus posterior, it can be achieved safely with the cryo balloon. And PVI plus posterior wall proved some superiority to PVI only in patients with persistent AF, and in 1/3 of patients, RF was used to complete the posterior wall. Complications. So this is anatomically, this is where the phrenic nerve is. You can see the phrenic nerve is drawn out here in a green line from the superior vena cava to the IVC. It's essentially right in front of the right-sided pulmonary veins. The esophagus is in very close proximity to the left atrium. So those are the structures that you can get collateral damage basically from during an ablation. The atrioesophageal fistula was a catastrophic event. Thankfully, it's a very rare event. It's like a 1 in 1,000 chance of that. And I've only seen that with radiofrequency ablation. I have not seen it with cryo or any other technology. I think I presented this as an M&M at some point. I was either a fellow or junior faculty, and it wasn't really my case, but it was one that I presented because you can kind of see where this was actually, thankfully, did not penetrate into the left atrium, but it was a esophageal pericardial sort of connection there, or fistula, and they treated this with a needle stent in the esophagus. This was called a pericardioesophageal fistula. Thankfully, it didn't penetrate into the left atrium. You can get phrenic nerve palsy or permanent. So the chance of permanent phrenic nerve injury is about 0.1%. You can get a TIA or a stroke. I've only seen one of those in my career during an ablation, at least the clinical. There are some studies where they've looked at brain MRIs after an ablation and they see micro injuries. But as far as a clinically relevant stroke or TIA, it's pretty rare. It can happen, but as soon as we have access into the left atrium, or in some institutions, as soon as they have access in the femoral vein, they anticoagulate the patient. We give them somewhere between 5,000 and 15,000 of heparin, depending on the patient's weight. And with that strategy and irrigation of our sheaths, it's a very rare complication. Cardiac tamponade also is pretty uncommon. Obviously, we'd have to perforate something and cause a pericardial effusion. And you can get tamponade during an ablation. It's not common. For those reasons, that radiofrequency ablation can cause phrenic nerve damage or esophageal injury, and cryo can cause the same types of complications, the world has and the industry has slowly moved into what we called pulsed field ablation, which is the new kid on the block. Pulsed field ablation is an ablation technique that uses pulsed electric fields to ablate cardiac tissue through the mechanism of what we call irreversive electroporation. Essentially, the electrical field punctures little holes in the cellular membrane, and depending on the amount of PFA and the frequency of PFA, you can cause irreversible electroporation and apoptosis or necrosis of those cells. That's the goal of PFA ablation. The entire world of electrophysiology, the entire industry is moving in this direction. And whoever falls behind, they're not going to have any business in the next several years. We participated in the ADVENT trial that I'm going to show you in the subsequent slides, and actually the Medtronic trial for PFA. We participated in both of these a couple of years ago, 2022, 2021. These are FDA approved. A lot of these other catheters are experimental and about to be approved. They're also talking about focal. So if you look at these catheters, they're meant to isolate the pulmonary veins in 1 or 2 applications, but the world is also going to move into focal PFA technology for other arrhythmias because it seems to have better efficacy and safety profile. We also participated in the VOLT trial in August, and that closed, and that's pending FDA approval. FARAWAVE was a company out of San Francisco that started several years ago. It was recently purchased by Boston Scientific and recently gained FDA approval, which was a very smart move. But essentially, it's a star-shaped catheter that looks like this. It can take different forms. You can make it into a basket or a flower. But this was the ADVENT trial that we participated in. It was a comparison of PFA to either standard radiofrequency ablation or cryoablation, and essentially the results were very similar. So non-inferiority, and it accomplished that. It showed similar efficacy and less complications, right? So you have no esophageal events, they've done close to 17,000 PFA ablations throughout the world. And in this study that was published in Nature Medicine, 0 esophageal events, 0 PV stenosis, 0 phrenic nerve paralysis. These are great, right? You can get some coronary spasm because of PFA application close to the RCA or the left circumflex. You can still get pericardial tamponade. So the small incidence of stroke, TIA, and vascular complications are still there. But the major adverse events were 0.98%. I used to quote patients at 2 to 3% chance of complication with standard ablation. And now, because we've transitioned to PFA, I'm quoting them about 1% chance of a major complication during the procedure. It's substantial, right? 2 to 3% versus 1% when it comes to major adverse events it's a big deal. Coronary spasm can happen. It usually happens if you're too close. So as soon as PFA came out, people are like, how else can I use this? So they take PFA and they applied it in the cavo-tricuspid isthmus to get rid of flutter. Well, the RCA is right there and you can cause spasm. Now that's treated. So people can give nitroglycerin right before they do that and it prevents the coronary spasm. But I'm just saying these things happen when people start going a little off-piste and trying to do their own thing. Hemolysis, so the rate of hemolysis leading to renal failure was low, 0.03%, and it occurred in 5 persistent patients and patients receiving more complex lesions and usually a large number of PFA lesions, so 143. So those are the patients that had hemolysis. On average, we do about 45 lesions to isolate the veins in the posterior wall. If you get above 70, that's when you start noticing hemolysis and possibly renal failure. We have a new protocol at the center to, if we think that we're going to do more PFA, we started giving them more IV fluids up until the hurricane when fluids were restricted. So, but yeah, generally, if you hydrate them well, you can prevent any renal injury. The world adoption of PFA technology, quite rapid. I mean, we've exclusively switched overnight from cryo to PFA. Cryo worked, but it's PFA is faster and safer, and we have it, so everybody wants to use it. So for the more difficult cases, as I explained in one of my earlier slides, there's a component of the epicardium firing. So for the patients that have been chronically persistent or that I've tried a standard ablation and they're still having AFib, I often consult with our cardiothoracic surgeons, specifically Dr. Soltz, who does a lot of these epicardial ablations. But basically, the endo-epi convergent procedure it's just a more thorough ablation, and they ablate they get access through the pericardial space. They deflate the left lung. It's not a full thoracotomy, but they go through the ribs, and essentially they get the catheter behind the left atrium, and using radiofrequency ablation. By the way, this company is also working in a PFA catheter, but currently the one that they have is a radiofrequency catheter, heat energy, but essentially they ablate the entire posterior wall, and specifically the vestibule, the portion of the left atrium that's closer to the at the very bottom of the left atrium. And this procedure seems to have very good results. Typically, Dr. Soltz will also do ligate the vein of Marshall, which can be arrhythmogenic, and he also ligates the left atrial appendage with a left atrial clip that I will show you in a few slides. Some other kind of less common potential complications with ablation, but all in all, the numbers that I quoted you of like 2 to 3% with RF and 1% with PFA are pretty accurate. Stroke risk and anticoagulation, we use the CHADS-VASc score. This is the CHADS-VASc score for a CHADS-VASc of 0 or let's say 1. I don't think you ever have a 0% of a stroke per year, but close. But somebody that has a 1, roughly about 1% chance of stroke per year, 2 translates to 2, 3%, 4%, and then at 5 or greater, that number goes up to almost 10% chance per year of having a stroke. Typically, this is the calculator that I use to assess somebody's risk of stroke. There are other algorithms out there. But essentially, if you have a CHADS-VASc of 2 or greater, that portends about 2% chance of stroke per year. It's a class 1 indication to be on a blood thinner. For the, they say DOACs over warfarin. And for the patients that are more than 1 but less than 2, still recommend anticoagulation, but at a lower level of just not as strong of a recommendation. And aspirin has essentially completely fallen out of the algorithm. In fact, they say it can cause harm. So this is the schematic of what I just showed you, but 2% or greater anticoagulate, between 1 and 2% anticoagulate, but have a discussion, and it's a softer recommendation. DOACs over warfarin and aspirin is out of the algorithm, essentially completely. So if you compare all the OACs to warfarin, you have a less chance of stroke. Hemorrhagic strokes were half, intracranial hemorrhage half, all-cause mortality was improved, but GI bleeding was a little worse. This is a meta-analysis. Focus over here, please, for AFib. We use either 20 of Xarelto or 15 if their creatinine clearance is less than 50, 5 or 2.5 for apixaban. So 2.5 is if they're over 80, have a creatinine, they have to have 2 of the 3 here. So either over 80 and a creatinine of 1.5, some combination of 2 of these 3, or less than 60 kilos. Dabigatran, 150 BID or 75. This became generic last year. So if somebody complains about access or cost of these medications, consider switching them to dabigatran. And edoxaban, I just don't use it as much. I don't think there's anything wrong with it. It was the 4th medicine that came out, and I'm not that familiar with it. I mean, I may have 1 patient on it. This slide is important to me because I have a lot of patients with loop recorders, pacemakers, and defibrillators. And every time I have a device clinic, one of the nurses will come up to me and say, well, I've detected AFib. What do we do? What do we do? And well, it gives us some guidance. So if the episodes are longer than 24 hours, you should anticoagulate, especially if their CHA2DS2-VASc is greater than 2. But even for episodes that are between 5 minutes and 24 hours, if their score is greater than 3, you should anticoagulate. So this is important. And if the episodes are less than 5 minutes and their CHA2DS2-VASc score is not that high, you should leave them alone. This comes up almost every clinic or every other clinic. And sometimes you just don't know exactly what to do. Yeah. They're brief episodes. They have 1 minute of AFib in 6 months. This is the Hasbled score that assesses the risk of bleeding. We have the option of, for patients that are at moderate to high risk for stroke and have a contraindication to oral anticoagulation, you could consider left atrial appendage closure. This is the Watchman device, another Boston Scientific purchase that was very successful for them. And in patients with AF and moderate risk for stroke and high risk of major bleeding, on oral anticoagulation, percutaneous left atrial appendage closure may be a reasonable alternative to oral anticoagulation based on patient preference with careful consideration of the risk of the procedure. That's a 2B indication. This is the surgical clip that I described that the surgeon places at the time of an epicardial ablation. The advantage of the surgical clip is that you don't need anything afterwards, just about, although data suggests that a clip and a Watchman and anticoagulation is probably the strongest way to, the best way to reduce the risk of stroke. But generally, people want a Watchman. They don't want to go through a procedure unless you tell them that they're going to stop anticoagulation. And I'm going to go quickly here because these are, so risk factor modification. This is very important for internists and all of us, general cardiologists. So advise them to exercise, class 1 recommendation, it helps. It helps reduce the burden of symptoms, maintain sinus rhythm, and increase their functional capacity. Lose weight, very important. If you lose at least 10% of your body weight, you can naturally reduce your burden of AFib. This was a study that showed that 10% of your body weight loss, even without any medicine, reduces the risk of atrial fibrillation significantly. And if you rebound, your chance of recurrence of AFib comes back. But there's if you have linear weight loss, you have a pretty significant you can have a pretty significant reduction of your AF burden. So for the obese patient who wants to be in sinus rhythm, yes, we can do an ablation. Yes, I can cardiovert you and put you on drugs, but you also need to lose weight, and it's very important. And I tell them every time. Some people have come back and they look much thinner and they have a good result, and others, they just don't follow that. Smoking cessation, alcohol reduction, this is a great slide in my opinion. This is your overall cardiovascular mortality, right? We used to tell patients, well, a glass of wine is okay, but for the purposes of atrial fibrillation, it's a straight line. The more you drink, the higher the chance of developing atrial fibrillation. And also the World Health Organization has reduced we never recommend alcohol, but we used to tell patients, men, you can have 1 or 2 glasses a day, women, 1 or less. Now the World Health Organization, I believe, reduced that to 3 drinks per week. Treat hypertension. And as far as sleep apnea, sleep disordered breathing, there's just no clear benefit of CPAP, but you should, evaluate them. There may be other benefits to treating sleep apnea, but I'm not sure you're going to reduce their burden of AFib. And also caffeine consumption. I don't tell them have at it, but it really, you can drink coffee. It's probably not going to change. It changes their perception and how that you might feel a little more tachycardic, but it doesn't necessarily increase or worsens AF. So in summary, propose lifestyle changes to all AF patients to make their management more effective. Use oral anticoagulation in all AF patients unless they're at low risk of stroke based on their CHA2DS2-VASc score or have a true contraindication to anticoagulation. Do not use antiplatelet agents for stroke prevention. Do not casually discontinue anticoagulation. For truly asymptomatic patients or patients in permanent AF, rate control is fine, but they need close monitoring of their symptoms or development of symptoms and assessment of their LV function. So for those patients that are in permanent AF and they're rate controlled, I usually get an echo, if not every year, every few years, just to make sure that their EF is not deteriorating. Select antiarrhythmic drugs based on their safety profile and refer symptomatic patients for ablation early, especially if one antiarrhythmic has failed or even as first-line treatment if that's what the patient wishes.